Professor Scott Solomon. Are you with us, Scott?
Yes, I am.
How are you, Scott? Hello. This is Mohammed Sobhi speaking to you. How are you?
Good
We have
morning.
a lot of audience here in advanced heart failure, looking to you and your talk about the heart preserved ejection fraction, a new opportunity. And even after the new consensus yesterday, everybody is looking to what your opinion. Dr. Scott Coleman is, the PI of the Paragon and many trials of the heart failure. Dr. Scott, the floor is yours now.
Well, thank you very much, and I very much appreciate the invitation to come virtually to Egypt again. And I keep saying that one day I'm going to actually get to go there in person, and I'm looking very much forward to that. So I'm going to continue on some of the themes that you heard in the last lecture. I apologize in advance for some repetitive slides, but I think I will be able to show you some nuance that maybe you didn't hear before. I had the honor of leading the Paramount trial and the Paragon trial, and playing a key role in the Paradigm trial. So we've been studying Sacubitril valsartan for many, many years, and we're continuing to study that and other therapies in heart failure with preserved and mildly reduced ejection fraction. So I'll start with my disclosures over here. And as you know very well, heart failure with preserved ejection fraction, whatever we mean by that, is accounts for at least a third to a half of all our patients with heart failure. These patients have very similar signs and symptoms as patients with heart failure with reduced ejection fraction. And this is a disorder that is increasing in prevalence. In my own country, we are seeing much more heart failure with preserved ejection fraction as time goes on, probably because our population is aging and heart failure is a disease of aging. We've also been studying this disease around the world, and so we've seen that there are differences in the phenotypes between different parts of the world. In my country, we tend to see people who are more obese with diabetes, coronary artery disease. In Asia, for example, we tend to see a younger group of patients, more atrial fibrillation, less obesity. This is a disease, an entity that looks different depending on where you are. With respect to treatment, as you heard from the last lecture, we've been for many years between a rock and a hard place. And what I mean by that is that we have really only been able to treat this syndrome empirically. And if you look at the most recent clinical practice article in the New England Journal of Medicine written by Maggie Redfield, it says to do a number of things that we consider empiric therapy, like considering alternative diagnoses, treating symptomatically, decongestion with diuretics, lowering blood pressure, treating other comorbidities, rate controlling patients in atrial fibrillation. In fact, there hasn't been even a trial to demonstrate that maintenance of sinus rhythm is better in patients with atrial fibrillation and HFPEF. Diagnose and treat ischemia. Now, let me take a few of those individually because I think they're extremely important. There are certainly diseases that overlap with heart failure with preserved ejection fraction that are likely targetable diseases and that are distinct enough that we should make those diagnoses. And the two that I'm going to mention here are hypertrophic cardiomyopathy and amyloidosis. Hypertrophic cardiomyopathy, of course, is generally caused by myocyte sarcomeric mutations resulting in myocyte disarray and unexplained ventricular hypertrophy. And these patients, of course, can present with heart failure. But there are new therapies that are being tested, and some of which have been tested, that may target patients with hypertrophic cardiomyopathy. The other disease that we should identify in these patients is amyloidosis, particularly transthyretin amyloidosis. And of course, this can be caused either by a mutation or can be wild type. And it has been now estimated that about 10 to maybe 15% of patients with HFpEF might actually have amyloidosis. We can identify these patients on PYP scans, for example. There are a number of approaches, even cardiac MRI, but there are now targeted therapies, including transthyretin stabilizing agents and knockdown agents that might turn out to be very beneficial in patients with amyloidosis, and that are approved for use in certain places. I don't know if that's true in Egypt. Diuretic therapy is what we do empirically. There have been no clinical trials, but of course, as cardiologists, we know that our patients with HFpEF benefit from treatment with diuretics. Hypertension, we've realized that lowering blood pressure is a very good way to reduce the incidence of heart failure. And in fact, several trials have shown that aggressive blood pressure lowering, on the left, the HIVET trial, on the right, the SPRINT trial, reduces heart failure hospitalizations. Now, these were not specifically in patients with heart failure, but it suggests that lowering blood pressure is effective in patients with heart failure. I told you about atrial fibrillation before. It is very common in patients with heart failure with preserved ejection fraction. We see it in between 40 and 60% of our patients. And indeed, if you have atrial fibrillation and heart failure with preserved ejection fraction, your risk of cardiovascular death or a heart failure hospitalization is dramatically increased. We showed this in the TOPCAT trial. We've looked at it in other data sets as well. And in fact, after a atrial fibrillation episode, your risk is so markedly increased in the first 90 days, it's about 5-fold higher than it would be. Now, I believe that we should consider rate, not just rate control, but also rhythm control in our patients with atrial fibrillation, but this has not been tested in clinical trials. Now, with respect to outcome studies, there have been several studies looking at, as you've heard, looking at treatments that target the renin-angiotensin-aldosterone system. The CHARM trial looked at candesartan. The PEP-CHF trial looked at perindopril. The iPreserve trial looked at irbesartan, and the TOPCAT trial looked at spironolactone. And of course, as you're all familiar, in the TOPCAT trial, when we unblinded the study, we saw that there were two populations. We had enrolled patients in the US, Canada, Argentina, and Brazil, Russia, and the Republic of Georgia. And in the US and Canada, Argentina, and Brazil, the overall event rates in these patients was much higher than they were in Russia and the Republic of Georgia. We believe that many of these patients, in fact, didn't have heart failure. If you don't have the disease that we're trying to treat, you can't see a benefit. If we look at the data from the Americas, we do see there is certainly a suggestion of benefit in patients taking spironolactone. And for that reason, as you heard in the last talk, spironolactone is now part of the guidelines as a Class 2B indication on both sides of the Atlantic. I do want to caution you, though, because our own data from TOPCAT suggests that spironolactone is not a drug without potential hazards associated with it. And in fact, what we saw was that as GFR goes down, as kidney function gets worse, the benefit of spironolactone was attenuated, and yet the risk of spironolactone went up. So safety got worse and benefit got worse as eGFR went down, and it makes us less enthused about using spironolactone in patients with chronic kidney disease. Now, as you know, I've been studying sacubitril valsartan for 12 years, but well before there was a name, when we called this LCZ696, and as you know, this is a compound, crystalline compound that is composed both of valsartan, the AT1 receptor blocker, and sacubitril, which is a neprilysin inhibitor. So neprilysin is an enzyme that is responsible for the breakdown of biologically active natriuretic peptides, ANP, BNP, and CNP, as well as a number of other vasoactive substances. And so when we give this, we're both blocking the renin-angiotensin system and we're augmenting the naturally occurring vasoactive peptide system. Well, you already saw from the previous speaker the primary PARAGON results that I presented at the ESC almost 2 years ago. And as you can see, we did see fewer events in the sacubitril valsartan arm compared to the valsartan arm, but this just missed statistical significance with an upper 95% confidence interval of 1.01. But you also saw that there were many secondary endpoints that really did suggest that there was benefit. We saw more patients with a favorable change in New York Heart Association functional class in the sacubitril valsartan arm and fewer patients with worsening of New York Heart Association class in the sacubitril valsartan arm. So the net was a 45% increased odds of improvement in New York Heart Association class with a nominal p-value of 0.004. Now, we also saw evidence of improvement in quality of life. We measured this with the Kansas City Cardiomyopathy Questionnaire. More patients had a 5 or greater point improvement in the sacubitril valsartan arm, and fewer had a 5 or more deterioration. Very interestingly, we saw a really dramatic benefit, a 50% reduction in the composite renal endpoint, which consisted of renal death, reaching end-stage renal disease, or a 50% or more decline in GFR relative to baseline. You've already heard what I told you about spironolactone. Here we see that kidney events taking sacubitril valsartan. We saw the same thing, by the way, in heart failure with reduced ejection fraction in PARADIGM. Well, it was very interesting when we looked at the pre-specified subgroups, as you've heard. We saw that there was greater benefit in patients with ejection fraction at or below the median, and in women. I'm going to show you these data in a bit more detail to give you more of a flavor. So these are the quartiles of benefit that we saw, and as you can see here, we are seeing evidence of benefit in the first 2 quartiles, some attenuation in the third, and then really nothing much quartile. Now, we have been able to, in a pre-specified pooled analysis, put the data from PARAGON and PARADIGM together, and you saw some of this in the last talk, but this is what happens if you do a pooled analysis of these 2 trials, and it would have been what we would have seen had we done these trials together as one giant trial. We would have saw benefit in terms of every single endpoint, highly statistically significant benefit for every single endpoint, including all-cause mortality, including cardiovascular death reduced by 16%, all-cause mortality highly significant, 12%. It shows you how the power of very large clinical trials. But we still would have seen what you've seen shown you before, which is this gradient of benefit that appears to attenuate as ejection fraction goes up. So shown here is ejection fraction on the x-axis and the treatment effect on the y-axis, and as EF goes up, there's an attenuation of that treatment effect. And it happens in both men and women, but interestingly, women appear to derive benefit to a greater ejection fraction than do men. And I think this explains the heterogeneity that we saw with respect to men and women. Now, why might that be? Well, if we look at ejection fraction in women, and we can look at this in many different data sets, we always see that women are higher, and especially women in heart failure. And this suggests that there is something different about these hearts in men and women that might account for this difference and why we're seeing a greater benefit to a higher ejection fraction in women. Well, before we unblinded Paragon, we had seen and published from both CHARM and TOPCAT the same gradient that we saw in Paragon, which is that the benefit of both candesartan in CHARM and TOPCAT attenuated as ejection fraction went up. So I think what we're seeing here is that the patients with heart failure and mildly reduced ejection fraction, the new name for what we used to call mid-range ejection fraction, those patients probably do benefit from the same therapies that we've been treating patients for years with heart failure with reduced ejection fraction. So I do think we can treat these patients. These are similar data from both candesartan across the spectrum, MRAs across the spectrum, and sacubitril valsartan across the spectrum. Very, very similar. And even when we break this down into women and men, we see a very similar pattern that women seem to derive benefit to a greater ejection fraction for all of these. Let me put this in perspective. The Paragon results, if we were to think of this in terms of the absolute benefit, the potential events prevented by treating 1,000 patients over 3 years, in Paradigm, in heart failure with reduced ejection fraction, we would have prevented 122 events. Overall in Paragon, we would have prevented only 54. But if we had looked at only the patients at or below the median ejection fraction in Paragon, we would have prevented almost the exact same number of events as we would have in Paradigm with heart failure with reduced ejection fraction. So we had presented these data to the FDA, and you already heard that they have now provided a new indication based on a 12-to-1 FDA advisory committee vote. Sacubitril valsartan in the United States is now indicated to reduce the risk of cardiovascular death and hospitalization for heart failure in adult patients with chronic heart failure. Benefits are most clearly evident in patients with left ventricular ejection fraction below normal. And they went on to say, ejection fraction is a variable measure, so use clinical judgment in deciding whom to treat. Well, we've recently presented at this meeting, the meeting in Florence, the Heart Failure Association, how many patients we would have benefited based on the Get With The Guidelines and the NHANES results. We calculated the numbers based on the Paragon data, and then we calculated a number needed to treat to prevent events with 3 years of treatment. And as you can see here, these numbers needed to treat are really quite small. They change a little bit depending on where you put those, the cutoff. But I think that if we did sex-specific cutoffs, the number needed to treat for women is 5, which is really pretty dramatic. These are data that will soon be published in JAMA Cardiology. We've also seen in Paragon that the patients who were hospitalized most recently, those who were enrolled within 30 days of a heart failure hospitalization, had the highest event rates and the greatest treatment effect, and suggests that this group of patients who are most recently hospitalized may be very good targets for this kind of therapy. I'm going to end just by telling you where we're going. Many of you are quite excited about the results of all the trials in heart failure with SGLT2 inhibitors, DAPA-HF, EMPEROR reduced, both showing a benefit in heart failure with reduced ejection fraction. And we are, of course, now almost finished, almost have results from the heart failure with preserved ejection trials. We're going to hear very shortly about EMPEROR Preserved. It'll probably be presented at the ESC. We're going to hear about DELIVER shortly after that. I'm leading DELIVER, and it's now a 6,200 patient trial. It's the largest trial in HFPEF. And we're continuing to test other therapies. The Fine Arts trial, which is now over half recruited, is testing a non-steroidal mineralocorticoid receptor antagonist, finerenone. As you also heard in the last talk, there are other approaches, including the shunt device that we're testing. that theoretically should lower the filling pressures in the left atrium by creating a shunt between the left and the right atria. So in summary, up until recently, therapy for heart failure with mildly reduced and preserved ejection fraction has been empiric. It's important to rule out other targetable causes of diseases. Therapies that have been beneficial in patients with heart failure and reduced ejection fraction are likely also beneficial in heart failure with mildly reduced ejection fraction. And stay tuned, there's going to be more information coming very, very shortly. Thank you very much for your attention.
Thank you, Scott, for this wonderful lecture. I have two questions for you. Do you hear me?
Yes.
Okay. First question, the HFPEF is, as you know, that it's different phenotypes in HFPEF, so it's difficult to be treated. So do you think that it is individualized? I mean, you are depending on heart failure, and also adding the second question, you are depending ejection fraction, which is sometimes it's a variable. So I think we need another tool to diagnose HFPEF rather than to judging on the phenotype and ejection fraction?
Sure. Well, so the question about phenotypes is very important, and I showed you some data showing that the phenotypes do appear different in different parts of the world. But just because we can categorize patients into different phenotypes doesn't mean that we know for certain that they will respond differently to different therapies. What we need to do is obviously test therapies in different phenotypes to see if that is the case. Now, the two phenotypes that have come out to be very clearly different in the PARAGON trial were ejection fraction and sex. So I think these are at least the first two phenotypes for which I think we have reasonable evidence that there is truly phenotypic therapeutic heterogeneity. I don't know that about other things, but you're absolutely right. There's the obese phenotype. There's patients who are non-obese and more likely, for example, to have atrial fibrillation. I agree with you that there's likely to be different approaches to treating these patients, but so far we're not. I think the only phenotypes that we're really pretty comfortable based on not just the PARAGON trial, but the ones that preceded are ejection fraction and sex. It'll be very interesting to see what we see in the SGLT2 trials.
Hello. We are really in the land of heterogeneity as regard the HFPEF, as you said and Professor Sobhi said. But do you think that we need more careful designs for the trial? I mean, like aldosterone. At the start, it did not show much data as regard the outcome. But nowadays, a lot of trials on molecular basis and the biomarkers benefited much from the aldosterone. So what do you think about the design strategy that we should pay attention to gain what we are looking for?
Well, I think you're bringing up an important point, which is that we should learn the lessons of history. And I've probably done more heart failure with preserved ejection fraction trials than almost anybody on the planet at this point. And we've been hopefully learning from our mistakes and learning from what we have discovered in the other trials. So, for example, in PARAGON, because of the results of TopCat, we ensured that everybody had elevation in natriuretic peptides and everybody had evidence of structural heart disease. In the DELIVER trial, knowing what we know about this ejection fraction heterogeneity, we've actually built into our primary endpoint the possibility that we could have a positive trial if we only see a benefit in patients with ejection fraction under 60%. That's an innovation that was based on the results of the prior studies. And we've also realized that looking at just time to first event may not be as efficient as looking at multiple events, because these patients don't have just one event. They come to the hospital for hospitalization often several times. We've realized that taking into account urgent heart failure visits that don't require hospitalization is important. And we can see with PARAGON that had we incorporated that into our primary endpoint, as we did, by the way, in DAPA-HF, as we're doing in DELIVER, we would have had a positive trial. So I think we have to take into account what we learned. And please, if you have any additional suggestions, we're continuing to study this disease, and I'm sure there will be more trials to come.
Thank you very much for your presentation. Come back to the phenotypes. Do you expect in the future we have some markers that help us to detect the success of some drugs in those patients and these different phenotypes?
Well, by markers, I'm not entirely sure what you mean, but I assume you mean biomarkers. And our biomarkers right now are pretty crude. We use NT-proBNP, for example, as a biomarker in this disease. But we don't have any disease-specific biomarkers. What I think we really want to do is find targeted therapies for molecular targets that we think are at play. And one of the problems in HFPEF is that we're not completely certain about what is the molecular problem, what is the process, and therefore we don't have a target. With amyloid heart disease, we've been very successful recently because we know that for transthyretin amyloid, it is the misfolding of the transthyretin that's the problem. And so if we can block that, either with a stabilizing agent or a knockdown agent, we can essentially fix that disease. And we're seeing some pretty dramatic benefits in those trials in both neurologic disease and cardiovascular disease. We need to find a true target here. And I think for that, we're not quite ready because we don't clearly have a molecular etiology that we're all convinced is the underlying pathophysiology of this disease.
Professor Solomon, thank you very much for a fantastic presentation. I'm Hani Raghi, one of the cardiologists here. My question is not about the hard endpoints like mortality and hospitalization, but about quality of life, because sometimes it gives us indicators. I mean, for instance, in patients with TTR amyloidosis, sometimes we diagnose them if we had missed them because they don't respond very well to ACE inhibitors and beta blockers. Their quality of life is really, really bad, and then we might look again. So in patients with HFpEF, whom we put on Sacubitril valsartan, in the trials, what was the quality of life indicators? I mean, what was the kind of symptomatic improvement? And when would you stop giving them Sacubitril valsartan if they did not improve clinically at all? I mean, would you just keep them on it, or is there clinical improvement? Because with HFrEF, we have like some more tangible things we can measure. But with HFpEF, it's really the symptoms, you know. So
yeah, and
what do you say about that?
I think that's true. Although I would say that there are lots of ways we can assess a patient's symptoms. One, we used an instrument in these trials called the Kansas City Cardiomyopathy Questionnaire. It's not perfect, but it's a reasonable way, a set of questions the patient answers themselves. New York Heart Association class gives us a sense of what they can do functionally. And although it is crude, it does give us a sense of how functional these patients actually are. And when we move that, if that changes in a trial like this, I think we can feel that, yes, they did improve their functional status. When a patient goes to the hospital, they don't go to the hospital to be hospitalized for heart failure if they're feeling well. They're obviously feeling poorly. The quality of life measures that we use in the trials, I think, tend to underestimate the benefit, because we don't actually measure quality of life the day before they go to the hospital. It's done at a very set times, and so we often are missing the decompensations. But I think the point you're making is really very good, which is that we do want to treat people so that they feel better, so that they can do more. We do have data from both Paradigm and Paragon that is the case. It does seem to attenuate as ejection fraction goes up, although not as much as the heart failure hospitalizations. We do see benefit of the Kansas City Cardiomyopathy Questionnaire score even across ejection fraction. So people still might be feeling better. But there's a lot of heterogeneity. Some people feel a lot better. Other people don't seem to get as much of a benefit in terms of how they feel.
Thank you, Scott, for this wonderful presentation and interactive discussion. And I hope to see you soon face-to-face in advanced courses. Thank you very much, and have a nice weekend. Bye-bye. Bye-bye.
You too. Take care.